Good afternoon, everyone. My name is Jenna Webb. I work with SHA Communications, and I'll be the moderator this afternoon. The program for the afternoon will include a presentation as well as some opening and closing remarks. And with that, I'll turn it over to Scott Livingstone to kick us off.
Thanks, Jenna. Good afternoon. Joining me today are Dr. Susan Shaw, our Chief Medical Officer from Saskatoon, Dr. Rashad Hansia, our Physician Executive for Integrated Urban Health, and they will both be speaking later in the news conference. Also joining us is Dr. Jenny Bazaran, our Senior Medical Information Officer, who will be available in the Q&A section of the presentation. Before we get into the heart of the presentation, I'd like to start by acknowledging that we are doing work on better updating you on outbreaks across the province. For now, I'd like to provide this verbal update. As you know from the provincial update today, there are 18 new confirmed cases in the far north. 5 of them are in Loche, with the remainder of those associated cases in communities throughout the northwest. This is not unexpected. Our aggressive testing and contact tracing is helping us identify and isolate people who are COVID positive and may be at risk. So while we must be cautious, we also know our measures are doing what they're intended to do. In terms of Lloydminster, although there are 2 confirmed cases in the north zone, there were no new cases associated with Lloydminster reported in the provincial update today. However, we are remaining vigilant about this situation and continue to engage with local officials about how we can improve information flow and sharing with the community. Regarding Prince Albert, there is 1 new case in the provincial update associated with Prince Albert. This case is not associated with the PA Victoria Hospital outbreak. All other testing results so far associated with the outbreak at PA Vic Hospital have turned up negative. An outbreak has also been declared at a dairy facility in the Saskatoon region. At this time, an active case investigation is underway, and based on that investigation, there has been no identified need for a public service announcement because of low transmission risk to the public. It's a single employee of that facility at this point in time. As previously discussed, the declaration of an outbreak can be triggered by low case numbers, as low as 1 confirmed case. Immediate measures are being taken to reduce COVID-19 transmission at this worksite and with identified contacts. As the local MHO assesses the situation and assesses risks, more information will become available. If deemed appropriate to protect the health of the public, we will issue a public health advisory. The local MHO and SHA are committed to being transparent with public and protecting their health, so while we are safeguarding the privacy of individuals involved in these active investigations. This is a developing situation, as I said, and we will continue to share more information as it becomes available. I'd like to acknowledge the patients, families, staff, physicians in our northern communities of Loche, Laval, Prince Albert, and also Lloydminster, and all parts of Saskatchewan who've been impacted by COVID-19. Our thoughts are with you daily, and as a system, we are doing everything we can to support you. I'd also like to thank the staff who have generously offered to be redeployed to work in these areas. Your willingness to respond on behalf of Saskatchewan residents is humbling. Last week during our modeling update, we introduced you to something called the effective reproductive number, which is the average number of people one person with the virus in Saskatchewan is likely to infect at a current time after all the effects of current interventions have been factored in. We committed to providing you with this value each week in hopes that together we can keep it below 1. As of May 3rd, the effective reproductive number in Saskatchewan is 0.97. We're concerned that this number is increasing and are monitoring it very closely. No different than we are concerned about recent case growth increase across the province. It's important to understand how every person's actions contribute to helping us ensure that we control the spread of COVID-19, and that's what's really what an effective reproductive number is all about. We recognize that certain components of the economy are opening, but most of the restrictions remain in place, and we need Saskatchewan residents to continue to adhere to these. I continue to urge everyone across the province to practice safe physical distancing, appropriate hand hygiene, and gathering in only small circle of family and friends. It will continue to be an important part of what we do even as we contemplate how we move forward. Today, the SHA is releasing its service resumption plan designed to provide everyday health services to Saskatchewan people and our ongoing commitment to serve the health and well-being of our province, today and every day of the year. The plan was built in partnership with the Ministry of Health, with physician leaders and patient and family advisors, and will continue to partner with these people going forward. This is a gradual phased-in plan that will allow for the resumption of health services in both urban and rural communities across the province. The primary consideration in this process will be patient and staff safety. Before I hand it off for a more in-depth presentation, I'd like to note a couple of key things about the plan. One, it's both flexible and adaptive. It will not be a one-size-fits-all approach. It's more of a framework. It will be mindful of the different local dynamics in the province, including accounting for the outbreaks that may slow the service resumption in certain areas of Saskatchewan. And make no mistake, this plan is necessary. The reality is we need to start to resume some services where we can. While there are risks to resuming services, there are also risks if we don't. When people don't get everyday health care, their conditions can escalate. That is why we need a plan in place to start to ensure that people get the care that they need. As part of this process, we will continue to work with our union and physician partners at each phase. We have had some initial discussions with them on this plan. We know there's more work to do. And we will continue our conversations with them over the next 2 weeks. I do want to thank them for their efforts. We recognize that it's the membership of our unions and our physicians who have stepped up during this pandemic period. We also recognize that they will have concerns at times, and we will work to address these concerns, but we know we share a commitment to the safety of both our patients and our staff across the province. I believe we have a shared understanding that as our risks escalate, we will continue to defer the everyday services that keep our Saskatchewan people healthy. Before I hand off to Dr. Rashad, I want to walk you through the Resumption plan. I'd also like to take this opportunity to thank healthcare workers across this province. The plan reflects the value of your work, and we appreciate what you do for Saskatchewan residents each and every day. And with that, I'm going to turn the presentation over to Dr. Rashad Hansia.
Thank you very much, Scott, and thank you everyone for this opportunity. I'd like to state at the outset, as Scott has mentioned already, that although I'm presenting this work is really the work of a whole lot of operational leaders across the province, as well as their physician co-leads and numerous other people in collaboration with the Ministry of Health. I would also like to acknowledge my co-sponsors in this work, Corey Miller and Mark Wyatt and Denise Maxa from the Ministry of Health. And with that, I'd like to commence the presentation. Next slide, please. Okay, so the aim of this service resumption plan is to safely resume the healthcare services to meet the needs of the people of Saskatchewan, while simultaneously ensuring the safety of our staff, patients, residents, and of course physicians as well. Next slide, please. So the outline of today of this presentation will be to share with you some considerations that went into the plan, as well as some considerations that will remain forefront as we implement the plan. We'll also cover some of the immediate actions that will take place as part of this plan, and then I'd like to give an overview of the stages of the plan at a very high level, as well as some triggers that will help us to determine when to move forward and backward within the plan. I'd also like to discuss some of the interdependencies between various services, service lines, and resource requirements, which are really relevant to how this plan is implemented. Next slide, please. Okay, so really the focus of the resumption plan is to work on expanding everyday health services. Those are the services that keep the Saskatchewan residents healthy and allow them to stay healthy. These are the services that we aim to provide as close to where people live as possible. During the course of this pandemic, we've encountered and implemented many new ways of working, such as virtual care, as well as online groups. And these are initiatives that we absolutely need to continue going forward, as they remain central to the way services will be delivered as we serve the people across the province. We also need to adapt to, firstly, prevent community transmission of COVID-19, but then also to meet the projected needs of people with COVID-19 that we know or expect will occur. But simultaneously, we also want to continue delivering services to those people who require health services for non-COVID-19 conditions. Next slide, please. The plan is provincially developed and locally delivered. And we believe that this is essential in the resumption of services, as these need to span across urban and rural settings throughout the province in a phased and adaptive way. Each of these phases of the plan that I'll go through in a short while will only be contingent on our ability to successfully limit the spread of COVID-19 cases, which we will continue to monitor through key indicators, as well as looking at some of the triggers, which I'll also go into in a little bit more detail just now. So some of these triggers, for example, will include adequate supply of PPE, personal protective equipment, as well as ensuring the safe flow of patients, as well as providers, including physicians and staff, through the facilities. We want to acknowledge that there will be variation in how the service resumption plan is executed and implemented across the province. And this is important to recognize and to know, because different communities will be experiencing different parts of the pandemic and different numbers of COVID-related infections, as well as potential outbreaks at different points in time. Next slide, please. So I'm sure that you can appreciate that extensive planning is required to accommodate all of the various interdependencies of the programs and services required for this resumption plan. A really good example of this to me is laboratory medicine, which at the moment has lots of people redeployed from their usual activities. Chemistry testing, for example, lots of those people are now doing COVID-19 testing. And so any service resumption activities that are formed under the plan have to take cognizance of the fact that these people need to be redeployed, and we also have to maintain the capacity to perform COVID-19 testing while the service resumption plan continues. As part of the service resumption plan, in-person appointments will continue or will come online and be expanded, but these will only be done where necessary, where appropriate, and where it is safe to do so. Another very important component of a service resumption plan is designing flow of people through the facilities in a way that will minimize or reduce the risk of exposure or transmission of COVID from one person to another. Other novel ideas to be able to limit this risk of infection or spread of infection will be to stagger appointments so that we reduce the footprint of people in the facility at any given point in time. Prior to the onset of this pandemic, or at the onset of this pandemic, many educational programs have been forced to stop or be suspended, and that has negatively impacted the ability of learners to be placed across the organization. So the resumption plan contemplates including the resumption of learner services and placements, which is a key component of maintaining the health workforce for the SHA going forward. Next slide, please. So onto the phases of the service resumption plan. Essentially, the service resumption plan is split into 4 phases. Phase 1, as I mentioned, is the resumption of everyday health services, as well as the expansion of surgeries and diagnostic imaging. Phase 2 is the SHA-operated specialty clinic expansion of service resumption. Phase 3 really, and I'll go into a little bit more detail on each one of these phases. Phase 3 is an further expansion of the everyday services, where Phase 4 will see a return to a resumption of services to a quote-unquote normal situation. All of these phases will be implemented across the province dependent on outbreaks that are occurring, capacity to be able to perform these services, and that includes human resources, staff, physicians, as well as supply chain components like PPE. This plan will be based on our ability to adhere to public health orders, and the timing, as Scott mentioned already, will be carefully considered based on all of these parameters as the plan proceeds. You will notice that only phase 1 has a date attached to it, and that's May 19th, and that is deliberate because each of the phases needs to have careful consideration before it's implemented, and it would be premature to do so at this stage. Next slide, please. So more specifics on the phases then, beginning with phase 1. The surgical service expansion that I spoke about will be a phased expansion of surgeries from what is currently done, that is 3-week urgent and emergent cases, to 6-week urgent cases as well. And that will include several types of surgeries, including hysterectomies, cochlear surgeries, thoracic, and even some cataract surgeries. These surgical service expansions will occur in a ratio of 75% day surgeries to 25% inpatient surgeries. And that is deliberate in order to minimize the foot traffic and the number of people in the facilities at any given point in time. Diagnostic imaging services will also be increased, and so that will include MRI, CT, X-ray, ultrasound, and various other imaging modalities. And I'd like to just lift out 2 in particular. So MRI services will increase from the 50% of normal volume that is being done right now to 75% of normal volume in phase 1. CT services will also increase from what is happening at the moment, which is 55% of current volume, to 75% of usual volume. Endoscopy services, physical medicine rehabilitation, and other therapies will also be brought online and expanded during phase 1 of the service resumption plans, as will ambulatory care. And an example of ambulatory care will be urgent infusions, which will also be expanded for people requiring those services. Next slide, please. More of the everyday services expansion in phase 1 will include primary care services and primary healthcare services, and these will look at expansion of services available in communities such as chronic disease services, so services for people who have diabetes, congestive heart failure, and COPD, for example, but will also include things like well baby care, prenatal care, and other day-to-day health services. There will be a continuation, as I mentioned already, of virtual appointments, but there will be an increase in face-to-face appointments where those are appropriate and necessary and safe. People with chronic diseases, of course, will be prioritized in the system because it's clear that not providing the services that those people need, which are non-COVID related, could potentially lead to their decompensation and escalation of their illness to the point where they need further care, such as admission to hospital. And that is something that we want to avoid at all costs, if at all possible. In phase 1, home care services will also be expanded, and moderate risk clients will be prioritized in that phase of the resumption plan as well. Home care services will also be expanded to include things like bathing services, and public health, nursing and public health inspections will also be expanded to include all routine immunizations and an increase in inspections of long-term care, personal care homes, and group homes, respectively. Next slide, please. Additional services, and I won't go into detail on each one of these, but there are many other services that will be stood up in phase 1, such as maternal child health, kidney health, harm reduction services, and as I mentioned before, a resumption of learner placements as well. I do want to lift out mental health and addiction services in particular as well, to mention that phase 1 of the service resumption plan will include the provision of in-person appointments where that's necessary, and the resumption of therapeutic and day programming for groups of people of less than 10 or whatever subsequent public health orders put out there for us. The assessment of youth for courts or youth courts will also resume, as will the reopening of mental health short stay units. Next slide, please. So phase 2 then is really the resumption of SHA, Saskatchewan Health Authority, operated specialty clinics such as electrophysiology, cardiac catheterization lab, cardiac stress testing, and other outpatient heart monitoring activities. This will also include respiratory services and clinics such as sleep testing, respiratory outpatient clinics, and also tuberculosis treatment clinics. There are other specialty clinics that will also commence, like eye testing, dermatology clinics, and of course CAS clinics, and importantly, high-risk antenatal clinics as well. Next slide, please. So phase 3 then will be a further expansion of everyday health services, and that will include chronic disease management, wellness programs, and stroke prevention. Some examples of these include Live Well with chronic conditions and heart health programs. There will also be in phase 3 an increase in opioid agonist therapy services, as well as a further progression of learner placements and specialized services for people with developmental disabilities, autism, and brain injuries. Phase 3 will also see a further expansion of mental health and addiction services with the opening of social detox and addictions inpatient treatment services as well. Next slide, please. And on to phase 4 then, which is really the resumption of remaining services and back to what we would expect to be a new normal. We do anticipate volumes that were being performed prior to the advent of COVID-19 and this pandemic, but we know that with the new ways of working and delivering services, that we will probably reach a different normal and a new normal. Phase 4 is expected to take us back into those quote-unquote regular times. And that'll include things like all of the elective surgeries and the reopening of services such as the hip and knee outpatient clinics. Next slide, please. So on to the triggers between the stages, and as mentioned, we will be carefully evaluating the situation in each part of the province and making decisions on whether the expansion of services should continue or should be moved backwards at any given point in time. Those decisions will be based on empiric data, but also several triggers that will help us to decide that we can expand capacity, include the availability of staff and physicians, supply chain, so the availability of PPE, as well as capacity within facilities to be able to house people. Some triggers that will help us decide that we need to pull back on the resumption of services include the need to prioritize and maintain the priority of COVID-19 related services, including the assessment and testing centers, an increase in the number of COVID-19 patients in hospital would be another indicator that we would rely on to tell us that we need to reconsider or consider pulling back and moving back in a stage. Furthermore, redeployment of staff is a big issue. So as we see at present, staff are going out, as is the Saskatchewan way, to help out our neighbors, and people are moving across the province to help out where outbreaks are occurring. Where that happens, we will obviously have to consider whether it's feasible to resume services and not do so where it's not safe to do that. Workforce illness or people having to self-isolate is another thing that we'll be monitoring, because that can impact the ability to expand services significantly. PPE we've spoken about, but there are other supply chain issues that also need to be monitored, as well as public health orders, the community transmission of COVID-19 cases, as well as outbreaks. We also have to be cognizant of external factors, and especially this time of year, natural disasters like fires, because those would impact our ability to resume services, and those will also be taken into account in the service resumption plan. Next slide, please. And so the next steps in this resumption plan is that we will continue to focus on the prerequisites for service resumption that we've spoken about. These are really the foundation and pillars on which the service resumption plan will be based, and so it's important to have them in place. Regular communication will occur as services are brought back online, and that will be shared as quickly as possible. Healthcare teams will begin contacting patients on wait lists, so there's no need for people to have to phone their providers or their physicians at this stage. Healthcare teams will be making contact with people to let them know where they are and when their turn comes up. Interdisciplinary teams, including physicians, will continue to assess their waiting lists and triage patients and reprioritize people as their needs change for both surgical services as well as diagnostic imaging services that they may need. Patient flow design work, the patient flow design within facilities that I've spoken about just now, that work will commence immediately as well. And then local information, as mentioned, will be shared as and when it becomes available. So that's the end of the formal presentation. I'd like to hand over to my colleague, Dr. Susan Shaw, to speak to us as well, please.
Thank you, Dr. Hancia. As we navigate through the initial phase of the service resumption plan, we will proceed thoughtfully to maintain a balance between providing care to all people while ensuring that the needs of our COVID-19 patients are met. I will conclude this presentation by just circling back to a couple of the key points that Scott made at the start. We must be flexible and adaptive. We know and recognize we have outbreaks in communities in the Northwest and in our facilities in Lloydminster and Prince Albert. This plan will be tailored to ensure it does not impact our response to those areas and ensures our continued ability to respond to the challenges they are facing. It is, however, necessary that we proceed both slowly and carefully. While there are risks to service resumption, there are also risks when people are not getting the everyday health services that they need. As a critical care physician who works in Saskatoon, I think it's important that we recognize this fact. I have seen patients where earlier intervention could have helped improve their outcomes. If we continue to operate the way we are, these risks will mount. And that is why this plan aims to balance both needs: COVID-19 responsiveness with a need to resume some of the everyday services that people do need to maintain their health. Extensive planning is required to accommodate the interdependence of the various programs and the new ways of working. Our established online programs and virtual care have become essential and will continue to play a role in the delivery of healthcare services across the province. To support the move toward introducing more in-person consultation, it will be extremely important that we all continue to practice the fundamentals of physical distancing, proper hand hygiene, and limiting contact with those beyond a small circle of family and friends. Together, we can do much to move toward a future that takes what we are learning from COVID-19 and makes our health system stronger. But it will take all of our efforts to make this a reality. Please help us help you.
Thank you, Dr. Shaw. We'll now move to the question and answer portion of the afternoon. I'll take questions in the room and also on the line. There's a question in the room to start.
Hi there, Arthur White-Crummy here. This is probably for Dr. Shaw and perhaps Mr. Livingstone. I think Dr. Shaw mentioned that she's seen cases where the prognosis of a patient has declined because of the wait in these services. I was wondering if we could have a little bit more detail about that, about how often we've seen that, whether we're tracking it in some way, and particularly whether any patients have faced permanent debilitation or death because of these waits.
Thank you, Arthur. So I think the primary thing is, I think this is I'm not alone, I would say many clinicians all around the world have noticed and have seen, we can measure the decreases in patients presenting to emergency rooms. And we've been consistently trying to message out to the public that we are here for you, your family physicians, your nurse practitioners in the emergency rooms, and we are all here for you. Yet we still see patients that are, for, I think, valid concerns about their safety, choosing to stay away. And those are the types of situations that I have seen. I think I can understand why they're concerned, but I want to assure the public that we are doing absolutely everything we can to make sure that the care and the experience is as safe as possible, while recognizing that we are needing to put protective steps in place, like the use of PPE and the physical distancing that can make it more challenging to make that connection with the patient that you do want to have.
Is there a follow-up?
Yeah. So you kind of suggested that this may be more a result of people choosing to stay away from health services because of concerns over COVID-19. But have you been tracking the people who have seen their surgeries or procedures postponed because of these delays in like a coordinated way? And are you able to provide any data about how many of them have seen severe complications or death because of the delays?
I don't have roll-up data available right now, and I'm not sure that we actually would be able to create an accurate picture. What I can tell you, though, is that our numbers of what we call ambulatory sensitive conditions, those are people who have chronic diseases that, when well managed in the community with, through primary health care and everyday services, do have a more success at staying away from hospitals. And we're starting to see increased numbers of patients presenting to the emergency room with what we call, again, ambulatory sensitive conditions. And we are seeing an increase of admissions to our medicine beds in particular. And that's why we're focusing on restarting our everyday healthcare services, which is making sure our patients have access to those things that help keep us all healthy and well.
Can we go to the phone lines for a question, please?
Mumford with Global.
Hi there. We're hearing a memo was sent out by the SHA saying that some COVID-19 patients in Loche will be transferred down to Regina hospitals. I'm just wondering if you could confirm this and tell us which hospitals, how many patients we might be looking at, and a timeline.
So I'm not familiar with that memo. I'm not sure. Susan, are you aware of that?
No, I'm not familiar with a memo that describes that. I think we did, yeah. I think that we have shared publicly and internally that inpatient admissions in the Loche are on hold right now, and that patients presenting that need admission would be transferred to local hospitals, most likely, North Battleford, Meadow Lake, but as a single health authority, if necessary, any hospital would possibly be on the list of where could be the best location, and perhaps it's a memo related to that, but I've not seen any plan or even considered that we would be specifically sending patients in the Loche to Regina. Our goal is to have safe care closest to home.
Is there another question on the line, please?
We have Mark Smith with CTV.
Will Prince Albert's Victoria Hospital or the Lloydminster Hospital be excluded from phase 1 due to their current outbreak situations?
Well, keep in mind that the plan as outlined doesn't start for another couple of weeks, and the usual incubation period, as well as the period in which we keep staff and patients and close contacts isolated, is 14 days. We're already seeing staff in both facility meet those 14-day requirements and be available to that facility. So right now, as you know, there is some diverted care in both those facilities, but we hope as the outbreak appears to be under control and with intense monitoring at both sites, we feel that, in 2 weeks we'll know better what the answer to that question is. But today we can't say, because right now we're still in outbreak mode, but lots of work going on to help control it both locally. And as I said, with staff coming back to the facility now because they've met the 14-day isolation and have been tested negative, that's also a good sign, because that's one of the reasons for the diversion wasn't because of the COVID cases, it's because we had staff that were impacted by contact with COVID patients.
Can we take another question from the line, please?
We have Alicia Bridges with CBC.
Yes, thank you. The plan mentions that there will be more inspections at long-term and personal care homes. Can you explain what kind of inspections you mean and why that is not happening already?
Do you want to talk to that?
I don't have specific details on what is involved in each individual inspection, but I know that guidance has come from the Chief Medical Health Officer and that the public health inspectors have criteria which they use to do those inspections. As part of phase one of the expansion or the resumption of services plan, we do anticipate an increase in the number of those inspections because part of this is to continue, as I mentioned during the presentation, to continue providing service to not just people with COVID, but also vulnerable people in the population who are not COVID related, and an attempt to prevent the transmission of community spread of COVID infections.
We'll take another question on the line, please.
We have Lisa Schick with CGME.
Hi. We know some medical testing was kind of put aside or slowed down because of the need to process tests for COVID-19. What can you tell us about how that might have affected patients in healthcare delivery, if there was any kind of testing that was put aside more than others, and what the backlog is like and what the plan is to tackle that backlog?
Well, I'll start, but to keep in mind, at the same time that we increased our testing across the province for COVID-19, including the deployment of multiple GenExpert machines, which don't rely on single labs, which does take the pressure off the two central labs, in particular the Roy Romano Provincial Lab in Regina, which has been our main go-to lab throughout COVID, but we also have spread the wealth to ensure that we have testing capacity as we move forward to closely monitor outbreaks, identify who we need to test, and build testing capacities so that we can continue to deploy work, but whether it's on COVID or non-COVID. With respect to what tests haven't been done, you've got to remember at the same time, we turned off the system with respect to elective surgical procedures, elective other types of stuff. So things like preoperative testing would have been way down. So I'm not aware of any tests that have been put to the side during that would have been required on an urgent basis or been required to provide service. So for example, if we're postponed your surgery, we're not going to call you in for pre-testing, and that would have taken some of the pressure off the lab and allowed us to deploy those staff to COVID.
Can we take another question from the line, please?
We have Becky Zimmer with Glacier Media.
Good afternoon. I've talked with Northern leaders in the past, and everyone I've talked to, they talk about the pressure that they're under when it comes to food security and living situations and lack of housing. There's supposed to be 100 more healthcare workers going up there. How is SHA responding to the more pressure that's going to put on the system up there?
So the number of employees that would be brought in both physically on the ground and virtually to Loche and surrounding areas has always been contemplated with respect to also supporting individuals who live in northern areas with respect to both accommodations. We have, as you likely know, through connections through the local community in Loche, the Friendship Inn is providing meals for those up there. And we also have a central government EOC with our public safety agency that is supporting the work across the north. So the other thing that we are doing where we can is we do allow folks where they can, for example, with contact tracing, to work virtually so they don't actually have to go into the communities and take up an isolation unit or a residential suite that might be better off for a patient. But it is something that was considered before we were sending people up north, and it would have been included in the accommodations needs for the total north as accommodating staff that would be going up there.
There's another question in the room.
The RT number that we have now being just around 1, I know that it was previously said that that would be a threshold for sort of evaluating how our public health measures are working. So what does that tell you about what we might need to do differently, or whether those measures might need to be strengthened? And what is the use of providing a single RT number when we have such a diverse regional outbreak situation? Can we have something more broken down?
Okay, so I'll start. Jenny's on the phone, so she'll be able to follow up. But I would say to start, and I did mention this, the number's gone up, and we know the number's gone up for a couple of reasons. One, we're seeing more cases for sure that would have an impact on it. As well, I think you got to remember that as we do this work, and use Saskatchewan data, we're putting as much recent data in there, but many of the new cases we see today are not cases that were infected yesterday. They were cases that have been infected over the last couple of weeks. So the thing to remember with COVID is we're always playing catch up with respect to where we identify new cases. So it's a concern, and it's one of those measures that we're going to be closely watching as things go forward. But it also is highly impacted, not just by the number of cases, but by perhaps by the pulling back on certain public health restrictions, social distancing and what. And we see that in other jurisdictions where they have modeled out, and Jenny is much better to speak to this, but I know through the modeling activity, one of the challenges has been is you apply a measure to what you think the adherence to public health measures are, and it's one of the things that determines how successful you are. So in the modeling, they would apply different numbers to those public health things, to social distancing, other public health measures, to see what the impact would be on the RT. But Jenny, I've exhausted my background, so I'll pass it over to you to answer Arthur's question.
I will also know that Dr. Shahab is on the line as well.
Sorry. Go ahead, Jenny.
Okay, thank you. Yeah, no, that's a really great question. Just following up on Scott, of course, we're monitoring this, and we are concerned that it is increasing. It does measure beyond the cases. It kind of gives us a sense of the underlying situation. So exactly as Scott was saying around how well are people following restrictions. That we know it's difficult with the weather being quite nice and people wanting to see friends and all of those, and so that measures that. It also gives us a sense of potentially the people who may be asymptomatic, and so they have no symptoms, they're not aware that they may have it, and could be contributing to the spread. So it gives us a sense of that. Onto the second question around one number for the whole province. We're also aware, of course, that this is a provincial number, and that was our first task at hand. We are currently right in the process, as we're speaking, to understand how to measure it in different areas, and we're hoping to have that out relatively soon with kind of a larger category, so different areas, and then hoping to narrow down into smaller areas with time and as we get more and more information and data. Recognizing again that these areas, while we can measure what's happening, the current underlying situation in these different areas, they're completely interconnected because people move between, both for personal reasons, but even patients as they come in for whether it's come to hospital or for appointments or any other number of activities. And so while it represents that underlying number in that area, we have to still recognize that it's still connected. What affects one area also will affect other areas. So it's really more important to focus on the trending of it and to say, how is it increasing? Is it decreasing? How quickly is it increasing and decreasing? So that's the view that we're using with our modeling.
And just one quick follow-up. In phase 4, there's not a lot of detail about what procedures are going to be waiting until the end of this. We just have some elective surgeries. Could you provide a little bit more detail just to give a sense of who might be waiting until the end to get their surgeries resumed?
There are very many people who are waiting for elective procedures, and there's a wide range of those. I mean, just to name a few, so people are waiting for hip replacements, knee replacements, those kind of non-urgent surgical cases, but that actually bring a lot of discomfort to people. So those are sort of important, not necessarily emergent cases. And it really talks to those cases as well as everything else in the system that's not being ramped up through the first 3 phases. It's a return, as we mentioned, to a kind of normal, but really a new normal, but trying to get back the rhythm of the services that were being provided before COVID.
That completes all the questions that we have today. Thank you very much.